Chair. I'll start again. Good evening and welcome back to the Lipid Panel. My name is Dr. Dan Soffer. I'm the co-chair of programming for the Lipid Panel, working alongside of Dr. Ann Carol Goldberg and Brittany Thompson. The Lipid Panel was conceived to be the lipid clinic conference on a national scale. For those of us lucky enough to have in-house colleagues, Lipid Clinic Conference is a great way to debrief after a busy clinic, to review diagnostic approaches, how to interpret clinical findings, and generate therapeutic strategies, and to come together with colleagues. For the rest of us who feel like we're on lipid islands, conferences like this remind you that you are not alone. And if you have cases that you want to be presented at future conferences, please email Brittany at bthompson@lipid.org with your suggestions, and she'll put that in the chat for today. In this series, we will review common presentations of rare diseases, atypical presentations of common conditions, and sometimes even just common presentations of common conditions. And we'll try to cover as many important clinical topics every lipid specialist needs to know. This series is meant to be a monthly coming together of rising stars like FNLA lipid scholars and early career lipid specialists with more experienced colleagues. Look for our schedule posting for final Tuesday of every month. And this evening, I'm joined by a superb panel. Dr. Deepak Vedamurthy will be presenting the case. He's a preventive cardiology fellow on the clinician research track at Pennsylvania Hospital in Philadelphia and interested in pursuing additional fellowship in cardiometabolic health. Dr. Guy Mintz will moderate the program, and our panelists include Dr. Nicholas Marston and Brett Cucchiara. Dr. Marston is a cardiologist at Brigham and Women's Hospital, an assistant professor of medicine at Harvard Medical School, and investigator and clinical trialist at the TIMI Study Group. Dr. Marston attends in Preventive Cardiology Clinic and Cardiovascular Genetics Center, where he cares for patients with genetic dyslipidemias, premature coronary disease, and inherited cardiomyopathies and arrhythmias. Our other panelist is Dr. Brett Cucchiara. Dr. Cucchiara is a professor of neurology at the University of Pennsylvania and vascular neurologist. He also takes care of my mother, which is probably his most important task. I think it is also worth pointing out that in general, the neurovascular surgeons at Penn follow the recommendations of the neurovascular team before taking patients to the OR. And that's pretty unique practice, I think. In a minute, I'll turn over our direction of our program to our moderator, Dr. Guy Mintz. Dr. Mintz is a diplomate of the ABCL, fellow of the ACP, ACC, and NLA. He's director of cardiovascular health and lipidology at Sandra Atlas Bass Heart Hospital and of apheresis at the Northwell Health System. So welcome to all the lipid panel. Welcome all to the lipid panel. Dr. Mintz, I turn this program over to you, and I really look forward to hearing what we all have to say tonight.
Thank you, Dan. We have a very distinguished group of people, and without further ado, I'm going to let Deepak present this case for us.
Sounds good. Let me share my desktop here. All right, is everyone able to see my screen there? Are you able to see my slides?
Yes.
Perfect. All right. Well, good evening, everyone. Thank you very much, Dr. Soffer and the NLA, for offering me this opportunity to be present with this bunch of wonderful panelists. So today we're going to talk about a case scenario. So I just want to give a heads up. This is not a detailed case presentation. So we're going to talk about a case that we encountered a few months ago, and we're going to highlight the dilemma that we faced while managing this patient. So without further delay, let me proceed to the case. All right. So we have a 75-year-old lady with history of hypertension and hyperlipidemia on statins for 5 years, who presented to the lipid clinic after a recent hospitalization for hemorrhagic stroke. She initially presented to a regional community hospital like summer of last year for severe headache. She does not recall clear precipitating factors, but did report a history of lifting heavy weight 1 day prior to this episode. She also reported that her blood pressure was running on the higher side, like around 160 systolic, few days prior to the acute illness. Otherwise, usually her blood pressure as well as lipids are fairly well controlled. So she personally does not have any history of clinical ASCVD, but she does have subclinical atherosclerosis with a coronary artery calcium score of 400 a few years ago that resulted in her being started on statins.
All right, Deepak, let me just ask Nick a question. What does a calcium score of 400 mean to you, Nick?
Yeah, it's a good question. So we use CAC more and more in the prevention lipid clinic. And, really a threshold of 300 or above is really considered very high risk. So 400 really catches my attention. We often use 300 as kind of a inclusion criteria for trials and things like that. So, while any plaque or certainly over 100 is going to push you to start statin, over 400 is a lot. And so I'm glad that she is on rosuvastatin and a high intensity statin at that.
Okay, so we have a 75-year-old woman with hypertension, probably not well controlled, hypercholesterolemia, and a very high risk calcium score. Okay, Deepak, continue.
Okay, sounds good. So she has no significant history of like familial hypercholesterolemia in your family, no family history of premature atherosclerotic cardiovascular disease. She has never smoked in her life. She does not drink too much of alcohol. She's postmenopausal. And her home medications prior to this acute illness were just two, amlodipine and 10 milligrams daily, and rosuvastatin 40 milligrams daily. Okay. So in this setting, she presents to the emergency room. So she presents to the emergency room. Her vitals were okay, except that her blood pressure was high. She had a systolic of 180 and diastolic of 90. She had mild, subtle weakness on the left side. She had a CT scan, which showed a large right temporo-occipital hemorrhage with some subarachnoid blood as well as some subdural. So predominantly a lobar intracerebral hemorrhage was found on the CAT scan. So she went on to complete the stroke workup, and she ended up having a CTA, which showed normal intra and extracranial vasculature. No significant atherosclerosis was seen. Now, the lipid panel at the time of presentation, while she was on statins, is shown here. The total cholesterol was 143, triglycerides was 169, HDL was 38, non-HDL was 105, and the calculated LDL cholesterol was 71 milligrams per deciliter.
So let's hold that thought. And Deepak, while I'm going to ask Nick another question here, can you possibly change to presenter mode to get the slides larger? Nick, so the patient has an LDL cholesterol on therapy, thank you, of 71 milligrams per deciliter. Is that target by guidelines? Is that an acceptable number for us?
Yeah,
It's
another good question. I mean, she falls in this area between primary prevention and secondary prevention, right? Because she has not had an event, so she's technically primary prevention, but she has this very high plaque burden of 400. So, I would treat her more aggressively than kind of your usual primary prevention patients. And really at that degree of plaque, I tend to be aggressive. I would treat her, as an established ASCVD patient. And so I think getting her down to a goal of 70 would make sense in this case. And so I think that given her CAC finding, being on a high intensity statin with an LDL of 70 milligrams per deciliter, 71 milligrams per deciliter, I think that's pretty good preventive therapy for someone who has not yet had an event.
So you're happy at 71? You want to push it lower?
I think probably not. I think that if I had another reason, like if she had FH, I thought this was long-standing. If she had elevated LPA, elevated high-sense CRP, I would certainly look for reasons to be more aggressive. But for patients even with MI, technically the guidelines are below 70, and she has not had an MI or an event, and she's kind of right there. So probably, unless there's some other enhancer, I'd be okay with this.
Okay, so with a calcium score of 400, we consider that consistent with coronary artery disease, and 70 is our target in secondary prevention. Okay, Deepak, continue.
That's good. I've not highlighted here, but rest of her blood work chemistries are normal renal functions, liver functions, normal thyroid panel, and normal Lp(a) levels as well. Okay. All right. So she was then transferred from this emergency room to the main hospital at Penn. And she underwent completion of her stroke workup. She was, of course, seen by the neurovascular team, the neurosurgical team, and so on. So she had an MRI, which showed a large right temporo-occipital hematoma, as well as numerous small cortical, juxtacortical infarcts, presumably secondary to the mass effect from the male intracerebral hemorrhage. She also had a CT venography that showed no cerebral venous sinus thrombosis. She underwent a cerebral angiography to evaluate for evidence of reversible cerebral vasoconstriction syndrome, vasculitis, aneurysm, AV fistula, or AV malformations as a possible alternative etiology for her hemorrhage and strokes. All of them were negative. She also underwent a transesophageal echo, which was negative for her cardioembolic source. Now, the etiology of her lobar hemorrhage on admission was thought to be due to uncontrolled hypertension.
So Brett, can you comment on this and maybe explain this for us non-neurovascular experts?
Yeah, it's a little bit of an unusual case in that she had both a lobar hemorrhage and evidence of small ischemic strokes as well, which turns out actually to be not that uncommon. When you do MR imaging routinely in hemorrhage patients, you actually find a lot of these little small punctate diffusion-weighted lesions consistent with small ischemic infarctions. And there's a lot of controversy over what causes those, but I think most people think it probably has to do with the aggressive blood pressure lowering that we administer early on in the course to these patients. In this case, I think there was some concern about whether there might be some unusual cause of her lobar hemorrhage given those small infarctions, which is why she underwent these other tests, the catheter angiogram and the TEE, which would not sort of normally be part of the workup for just a primary intracerebral hemorrhage. So in somebody her age with a lobar hemorrhage, the two main considerations would be hypertension or amyloid angiopathy. Both would be, on the table as possible diagnoses for her. And I guess the team leaned a little bit towards hypertension given her history and her MRI appearance.
Okay, great. Okay, Deepak.
All right, sounds good. Now, then when she was kind of closer towards a discharge, obviously she was stabilized, the workup was complete. When she was close to discharge, she was enrolled in the Saturn trial, and she was randomized to, we'll go through what the Saturn trial entails and so on, but she was randomized to the placebo group. I wasn't able to get the exact documentation and the research notes, but she was informed that she can receive other treatments for lipid-lowering therapy if her LDL were to get worse. So, and she was discharged from the hospital off statins. She was informed that the statins can increase bleeding risk, and therefore she was advised to see a lipidologist to be started on PCSK9 inhibitors.
Okay, so just maybe in one sentence or more, just tell the group what the Saturn trial was.
Sure. The Saturn trial is an open label randomized trial which aims to determine whether continuation versus discontinuation of statin drugs after spontaneous lobar intracerebral hemorrhage is the best strategy, and whether the decision to continue or discontinue statins should be influenced by an individual's ApoE genotype. So patients get randomized to either continuation of statin or discontinue statins for up to 24 months after the intracerebral hemorrhage. And they also had an ancillary study, which was looking at MRI markers of ischemic and hemorrhagic cerebrovascular disease, and whether the presence of these hemorrhagic markers on the baseline MRI influence the risk of recurrence of intracerebral hemorrhage on and off statin therapy. I do have a slide that kind of shows a little bit about what the exact inclusion and exclusion criteria were, just to point out the salient features.
Okay, so while we're perusing that, just let me ask a general question. So how does a trial like this get past the IRB, where you have a high-risk patient with coronary disease, obviously would be benefited from statin therapy? So what was the IRB thinking in terms of taking on this trial?
Do you want me to answer that question? So, I mean, it's
Sure.
not just the IRB, right? This is an NIH funded trial run
Sure.
through the StrokeNet, which is a center of 26 stroke research centers, each of which has 5 to 10 spokes feeding them patients. So this is a large trial that's been reviewed by multiple kind of different levels. And I think this is a fundamental difference between the neurologist and the cardiologist perspective on this question, right? Our clinical practice is actually routinely pretty much to stop statins in these patients. So to us, we see continuing statin therapy as the part that is questionable, not stopping statin therapy. And so this is where you get the controversy. And thus, obviously, there's equipoise in the neurology community and probably complete disagreement between lipidologists and neurologists on this topic. And I guess Deepak's going to show some of the data, which informs a little bit why neurologists are concerned about statins after intracerebral hemorrhage. But that's basically the answer.
Okay, Brett, thank you. All right, Deepak, let's go back to the
All right.
case.
So the patient now presents to the lipid clinic for her cardiovascular risk reduction as her total cholesterol and LDL cholesterol started getting worse off her statins. So she comes to the clinic like 3 to 4 months after discharge, and this is her lipid panel now. Her total cholesterol is 274, triglycerides is 159. The calculated LDL cholesterol is 197, and HDL is 47.
Okay, so Nick, what is this lipid panel suggestive of?
Yeah, this really catches your attention, right? I think for two reasons. One, not just because for one, the baseline LDL is so high, it kind of crosses that 190 threshold, that the line we've drawn to even consider FH. And then also just this means that the benefit that she had with the rosuvastatin 40, the high intensity statin, was really dramatic, right? Well over 50%, more like 60%. So that is a lot of benefit. And then to see, the LDL go up like that in a trial, 120 milligrams per deciliter is quite striking. We do a lot of lipid lowering trials, and we have to put in lipid monitoring committees to watch people's lipids who are blinded to the trial, and so that we're protected from it. And if the LDL goes up by 20%, we have to alert sites to this. So this is, obviously a striking increase. Certainly want to address it. I'm glad that the trial allows or permits PCSK9 inhibitor to be added. I think one potential for the design of the trial would have been to stop the statins, and instead of the placebo arm, it could have been a PCSK9 inhibitor arm. That way, this kind of issue would have been prevented.
Okay, great. So at this point, we could add PCSK9 therapy to lower LDL, and obviously we'd still have the same target of 70. So Brett, would it bother you if we lowered her LDL down to 70 again with PCSK9 therapy and maybe ezetimibe on board? So would getting it back down to 70 bother you with a clinical presentation?
Yeah, I mean, I don't think I would say it would bother me. I have no idea whether it's the right thing to do or not. This gets to what we're going to talk about in a little while, I think, is
Right.
like, are PCSK9 inhibitors different than statins in this respect? And I think we don't know. So I would say there's tremendous uncertainty.
Okay, great. I'm just setting the table.
Yeah.
Okay.
I think one of the issues, just to add to that, is again, this is, everybody focuses on their organ of interest, but this, she's never had a vascular event other than her hemorrhage. She's calcium scoring, yes, but she's never actually had a clinical coronary event. And her, interestingly, her CT angiogram of her head and neck showed absolutely no atherosclerotic disease whatsoever. And it's a pretty sensitive test for athero. I mean, we see it, even little tiny plaques, really well on CTA. So it's a little surprising there's such a disconnect between her, calcium scoring in her heart and her brain and cervical vessels.
Yeah, it's definitely interesting. And I think the discussion is going to come around to how low do we go, or is that affecting the cerebral vasculature, or is it something unique to statin therapy? So Deepak, go ahead.
Right, sounds good. So these are the questions and potential concerns that we came across with statins and LDL cholesterol levels. So we have come across data like not very strong data, but some data says statins may inhibit platelet aggregation. They can enhance fibrinolysis and reduce thrombosis. Thus, they can actually worsen intracerebral hemorrhage. We've also come across some studies that show statins may reduce oxidative stress and inflammation, stabilize plaques, decrease propensity for vascular disruption and hemorrhage, and therefore may end up causing less intracerebral hemorrhage. We've also come across some data that says low LDL cholesterol may actually increase permeability of vessel walls, causing arterial necrosis, microaneurysms, and thus predispose to intracerebral hemorrhage. So we were left with this question. So what should we do next for this patient? Should we prescribe statins, Zetia, and PCSK9 in the usual batting order? What is the current knowledge about statin use and intracerebral hemorrhage? And how low is too low as far as LDL cholesterol is concerned?
Okay, I think, those are pretty much some important questions for us to answer. So let's go with the last one first. In terms of how low is too low, I think, Nick, you have some of the data from the Fourier extension trial, looking at 5-year data with regard to safety. So can you just enlighten us on that aspect?
Yeah, absolutely. So we've got, the PCSK9 trials are really great for looking at very low achieved LDL, because those patients are typically on a background statin therapy, and they're starting off already below 100 in the trial, and you add a PCSK9 inhibitor and the LDL levels get very low. So for example, in the Fourier trial, the treatment arm that got evolocumab had a median LDL cholesterol of 30 milligrams per deciliter. And actually about 2,300, I think it was, 2,700, excuse me, had LDL under 20 milligrams per deciliter. And so one of my colleagues, Bob Giuliano, looked at specifically those very low LDL cholesterols, below 30, even below 20 milligrams per deciliter, to look at efficacy and safety. And I've done some of these analyses as well. What we've seen is that there's continued efficacy, such that the relative risk reduction that you're going to get per LDL unit of LDL lowering is consistent, below 40, below 30. So continuing to push down continues to have benefit for patients. And then importantly, it's also safe. So again, a Fourier trial was over 27,000 patients. So 13 to 14,000 were in the treatment arm and had a median LDL of 30 milligrams per deciliter. And there were no significant increases in any safety side effects other than a mild increase in injection site reactions, which were of course mild and self-limited. And so no increase in ICH, diabetes, neurocognition. These were some of the key things that we're looking at. Of course, no muscle aches or LFTs. And that remained true for that very low group of less than 20 milligrams per deciliter. The one other thing I'll say specifically to hemorrhagic stroke, because I think Dr. Giuliano's analysis really nicely showed this in the 2,700 patients that were on evolocumab and achieved an LDL below 20 milligrams per deciliter. They had just 3 hemorrhagic strokes during the whole trial follow period. So that's a 0.1% rate of hemorrhagic stroke over the 2.2 years. And that's compared to the placebo arm, which had a median LDL of 90 milligrams per deciliter of 0.5%. So, I think that if driving LDL very, very low were causing an increased risk of hemorrhagic stroke, I would have expected a lot more than 3 hemorrhagic strokes and a lot higher rate than we did see in that trial. So perhaps that speaks to this being more of a statin issue than a PCSK9 issue, but I think that those data argue against PCSK9 being involved in this, and also against achieving very low LDL cholesterol being involved. But it doesn't tackle kind of the statin question.
Right. Well, I'll just add in that that group was also on maximally tolerated statin therapy plus PCSK9. So statins were on board, looking at that group as well. All right. So Brett, why don't you give us enlighten us regarding statin effects and its potential cause of intracranial hemorrhage? intracerebral hemorrhage.
Yeah, sure. I think Deepak has a nice slide that looks at this. You want to show that Jeff Savers meta-analysis? Yeah, right. Oop, you just had it. Go back.
This one?
One more.
Okay.
Right. So, I think one of the key things to consider here is that there's a big difference between secondary prevention, so prevention of recurrent hemorrhage, and primary prevention, so prevention of an initial hemorrhage. And like everything, once you've had one fill in the blank disease, your risk of a second goes way up, dramatically up. And intracerebral hemorrhage is a relatively rare disease, right? I mean, it's about 20% of strokes overall. Lobar hemorrhage is probably even less. So the people at highest risk of recurrence are going to be patients with cerebrovascular disease, and really at the highest recurrence would be people who've already had an intracerebral hemorrhage. So this is data that kind of shows that if you look at the subgroup of patients with stroke in statin trials, so the Sparkle trial obviously included all stroke patients, and a subset of those were enrolled with intracerebral hemorrhage. And you see this pretty clear indication that there's about a 1.5 to 2 odds ratio, risk ratio doubling of risk of intracerebral hemorrhage or recurrent intracerebral hemorrhage. And it's both the heart protection study and Sparkle both showed this in the stroke patients. So it's more than one trial. It's not a huge number of patients, but for the world of stroke, it's a pretty big number, several thousand. And if you look at the patients, the B panel is the ones who were enrolled with an intracerebral hemorrhage. You see this 3.7 time increased risk of, recurrent intracerebral hemorrhage in the people randomized to statins. Admittedly, again, small number of patients, but, so I think this is the big question is, this is not a signal that you would see in a population that doesn't have cerebrovascular disease or has, low level of cerebrovascular disease, because it's a relatively rare occurrence. And, it's interesting, just, you were talking about the data from the PCSK9 inhibitors, you had 3 intracerebral hemorrhages in one arm and 5 in another, and 10, 15, 20,000 patients. And you can see here in the Sparkle trial, in the people who had intracerebral hemorrhages, you had 9 recurrent intracerebral hemorrhages in, less than 100 patients. So you had more, twice as many hemorrhages in less than 100 patients presenting with intracerebral hemorrhage than you had in the entire 20,000 patients in your PCSK9 inhibitor trial. So that just sort of gives you a good sense of how much difference the magnitude of risk is based on whether you're talking about secondary prevention, you've already had an intracerebral hemorrhage or not. So I think that's kind of the thing that gets stroke neurologists concerned about statins. And I think, the next slide was PCSK9 data, I think, in kind of a similar, now this is not stroke specific because there weren't trials that had just strokes. These were mostly people who had not had strokes. So it's not really comparable to the other side, but here clearly there is no signal. And I think that is definitely true, but there's also very few events because these patients are at very low risk. So you have very limited power, I think, to really tell if there is a signal. So I think the jury's out. I think we don't know is the bottom line. Certainly, if you haven't had an intracerebral hemorrhage, I would not be worried about this because the risk is going to be very low in absolute terms.
So Brett, what is the proposed mechanism for statin-induced intracerebral hemorrhage?
Yeah, I mean, I think Deepak talked about it in that prior slide. There's concerns about an antithrombotic effect. There's also concerns that just lipid lowering itself increases vascular permeability and increases, risk of hemorrhage. And there's kind of conflicting epidemiologic data about that. But there is some data that supports an increased risk in people with low LDLs independent of treatment. So those are, both possible mechanisms, but I think it's certainly not clear.
Right. So it could be how we lower the LDL, not necessarily the degree of lower LDL as was seen in the Fourier extension, but we don't necessarily know. Fair?
Yeah, and I might add a couple points here. And one thing I think is we're so fortunate in lipid lowering trials to probably have one of the best studied classes of medications ever in terms of randomized controlled trials. So I think, when it comes to case control or observational studies, we have the benefit of kind of, that's good for hypothesis generated, but now we have the trial data. And so I do think it's the meta-analyses that we should look to. there was one other meta-analysis published in Circulation in 2013 that also looked at 11 trials, all with prior CVD patients included. And so this is patients with prior cerebrovascular disease, 11 trials. And you can see here that the overall hazard ratio is 1.03. So a larger set here, and I think more reassuring overall. These are statin trials. The other thing I would say is there's a Mendelian randomization, and Deepak, I didn't send you this, but so you don't have this, but there's a Mendelian randomization from 2020 that nicely took an LDL genetic risk score, an instrument that would predict LDL levels, and then use that to do a Mendelian randomization, and found that LDL cholesterol, not only did it not, was it not kind of on a causal pathway or not associated with increased ICH, but it actually had a 40%, was associated with a 40% reduction in ICH. So that, I think, to me, along with the Fourier data going very, very low, really supports that it's not an LDL issue. I think furthering that, those other mechanisms you spoke of, that statin has, pleiotropic effects, and one of those could be, decreased thrombosis. We've seen in the Jupiter trial that statins reduce the risk of venous thromboembolism, like PE and DVT. So I think anytime you have a drug that's going to reduce thrombosis, there's always potential that there could be a mechanism that might increase bleeding. So that, I think, is perhaps a mechanism for how statin could have a modest effect in this very specific specialized population. So I think that's worth noting.
And Brett, do you think there's a difference between outcomes with regard to ischemic stroke versus hemorrhagic stroke, with regard to LDL reduction?
I mean, for sure, the outcomes are much worse after intracerebral hemorrhage. Disability is, about half of people with intracerebral hemorrhage are disabled, and probably more like a quarter to a third of people with ischemic stroke are disabled, looking overall. And you're much more likely to die of an intracerebral hemorrhage. So it's definitely a worse disease than ischemic stroke. That there's no question about that.
Interesting. So in this particular patient, we're pretty much convinced that the multiplier, for the event was her hypertension. So if you see these patients coming in with intracerebral hemorrhage and they have hypertension, should we, consider stopping their aspirin at that point? Should we consider stopping their statins? We're waiting for the statin trial. What, from practical standpoint, what should we be considering when we see these patients?
Yeah, so this is
at this point.
Yeah, this is a lobar hemorrhage, which is kind of a particular thing because the risk of recurrent hemorrhage in lobar hemorrhage is actually quite high. In some studies, depending on the underlying mechanism, but in the case of amyloid angiopathy, it can be as high as 15 to 20% per year risk of recurrent lobar hemorrhage. So it can be an extremely high risk population. It's a little different than a deep subcortical hemorrhage, like a thalamic hemorrhage or basal ganglia hemorrhage, in which the risk of recurrent hemorrhage is much lower. And blood pressure reduction certainly helps with both. It reduces the risk of recurrence in both lobar and subcortical hemorrhage. So that's super important. We usually stop antithrombotic therapy in these patients as kind of a matter of routine, unless there's some really compelling reason that they need it. The classic one we run into is atrial fibrillation. But in general, we would stop antithrombotic therapy.
Just a question from the audience at this point for you. Is there any information on blood pressure control in these patients with recurrent ICH in addition to the statin or LDL effects?
Yeah, we have very good evidence that blood pressure lowering reduces the risk of recurrence, and the effect is substantial.
Okay, is there a particular go-to therapy that you like?
Whatever the patient will take.
Okay. Good answer. All right.
Target should be less than 130/80, though. More aggressive is better.
Spoken like a true politician. Question here regarding being under the impression that PCSK9 inhibitors and statins do not cross the blood-brain barrier, and that the brain actually produces its own cholesterol. And we know HDL brings cholesterol to the brain, thus protecting itself from the rest of the body. So is this something we consider to be a truth?
Well, I mean, I think that, intracerebral hemorrhage occurs because of injury to the blood vessels in the brain. So it doesn't necessarily have to cross the blood-brain barrier. It just has to, affect the blood vessels in the brain, which clearly all of these medications do, because they're circulating in the bloodstream. So.
Okay, good. All right, Deepak, do you have, well, we just have our summary slide as far as ongoing questions. So I think, we're still debating whether this was a episode unique to statin. I think Nick has answered the question with regarding low LDL cholesterol and cardiovascular neuro events. But what else do you have with regard to potential mechanisms that we can talk about?
I don't have anything in particular to potential mechanisms, but again, we have already gone through some of this data. We have seen data, I guess, showing that LDL cholesterol is positively associated in ischemic stroke and inversely associated with risk of intracerebral hemorrhage, both by observational studies as well as kind of Mendelian randomization studies. But again, this is not consistently seen with randomized trials. So I guess that was part of the confusion that we came across. And some of the other studies that is kind of worthwhile pointing out and adds slightly to the dilemma are these large case control studies, which are population-based propensity score matched case control studies, which have compared statin use, statin users and non-statin users among patients who have intracerebral hemorrhage, as well as patients who have first-time ischemic stroke. Statins do not appear to affect the rate of subsequent intracerebral hemorrhage in these large case control studies, which enrolled a population of close to like 50,000. And similarly, even for patients who had first-time ischemic stroke, the risk of subsequent intracerebral hemorrhage was reduced by half in patients who are on statins. This was shown by two large observational case control studies, which actually looked also further into whether there was a relationship between the duration of use, with the current use, whether the intensity of statin use, whether any of these things cost or increase the risk of intracerebral hemorrhage. Again, the results were overwhelmingly in favor of statins. Again, this was kind of adding to this big random meta-analysis, which was showing that randomized control studies showed no evidence that statins increased intracerebral hemorrhage. But when you throw in observational studies into the picture, we found that statins were showing some benefits. So this kind of data was kind of adding to our confusion as to what to prescribe to that patient who came to a clinic on the first day. And also have some more Mendelian randomization analysis that showed that for each 1 millimole lower genetically instrumented LDL cholesterol, the risk of ischemic stroke was lower and the risk of intracerebral hemorrhage was higher. So there is lots of data showing both ways that statins increase intracerebral hemorrhage, statins may be protective against intracerebral hemorrhage. Low LDL cholesterol may cause intracerebral hemorrhage. In some cases, it doesn't make a difference. I guess that that kind of formed as the big framework for that randomized trial that is ongoing right now. The question, back to the question you asked as to why would the IR be approved? I guess because of all this conflicting data, we still don't have the answer settled as to whether statins are absolutely should be avoided in patients with higher intracerebral hemorrhage. So just wanted to show all the data that we came across that was kind of confusing to us when we saw this patient for the first time in the clinic.
And that's why we're presenting the case to elucidate this for all of us. But let me see, I used to have a professor on rounds all the time and say, if you don't consider it, you'll never get the diagnosis. So, the fact that you're bringing up this presentation, and we all see patients with intracerebral hemorrhage, stroke along the way, it's something to consider. Now, also, the statin trial had was looking at subgroups in ApoE, if I remember correctly. So I don't know if Brad or Deepak wants to answer the question. What is the role of ApoE subtypes, and how does that
Yeah, this
contribute
is
to hemorrhage?
this is
Before-
probably
yeah, okay.
yeah, this is probably not so much of a lipid reason for looking at ApoE subtypes. It's because in amyloid angiopathy, which is one of the major causes of lobar hemorrhage, there is definitely an association between your ApoE subtype and your risk of recurrent hemorrhage. And so that's, kind of one of the, and also with the likelihood of having amyloid angiopathy. So if you're uncertain as to whether it is or isn't amyloid, ApoE4 is much more likely to be amyloid angiopathy. And so that I think is the main reason that, that's being looked at in the trial.
So a little further down the road, we'll be checking ApoE on these patients.
And I think
as they
maybe
come in.
if I could just add that, because I think you showed a lot of data, and I think there should be a distinction between where there's mixed data and where there isn't. I think the data in the vast majority of people is very, very clear. Again, I can't think of another space where we have so many trials on one drug or one class of drugs. We've got, meta-analyses of nearly 200,000 people, 26 trials, all showing statins, don't increase the risk of intracerebral hemorrhage. PCSK9 trial data we've talked about showed the meta-analysis also good. So I think that, what we're talking about here in this case and with this trial is a very niche population or proportion of the population, people who have had intracerebral hemorrhage already, as Brett pointed out, it's rare. And then on top of that, maybe even having this specific genotype. So, I think that one of the takeaways here should be that continuing kind of statin therapies as you are is very, very safe. We've got a lot of great data to support it, and that it's not going to be causing ICH in the vast, vast majority of your patients. And then there's just a question mark on this one small proportion of patients. And that's why we do the trial. And I think it's going to be really interesting to see. We've actually never done a trial, as far as I know, that's stopped somewhere half of the patients have stopped. It's kind of the reverse of a statin trial. Instead of starting half on statin, you stop half on statin. And what's going to happen? We've seen observational studies that show about a 30% increase cardiovascular risk when you stop statin. So are we going to see that in this trial? And is that going to kind of overcome or offset any potential signal that is seen for the primary endpoint, the recurrent ICH?
Yeah, so I would just add to that, I'm not a statin hater. Don't get me wrong. I prescribe tons of statins because I'm a vascular neurologist, and most of what I see is ischemic stroke, right? So I totally agree with you that this is just patients with lobar intracerebral hemorrhage that we're talking about, and that's absolutely critical, because even if there is a small increased risk, the absolute risk facing somebody who's not previously had an intracerebral hemorrhage is so infinitesimally small that there's no way it has any real meaningful impact on the overall benefit of statins. So I totally agree with the point that this is all just about intracerebral hemorrhage patients. The only other thing I'd add is, when you look through the statin data and you see a lot of the reports that are out there, confounding is a huge problem with observational and case control studies with statins, because people who get statins and who don't get statins in clinical practice are different. And it's really difficult to adjust for all the unmeasured confounders. So I really think you have to focus on the randomized controlled trial data and not and maybe the Mendelian randomization data, just looking at the relationship between LDL and ICH, and not put a lot of stock in the observational studies. I mean, we've been down the path of all the diseases that statins cure. MS, like so many different things have been proposed, dementia, and it's an artifact of confounding, I think, and not a real effect. So that's one thing that I think is a pitfall.
Just another question for you, Brett. Are there ethnic differences in intracerebral hemorrhage? The MR data was done in Chinese patients. So is there a particular group we should be more aware of than others?
Yeah, it's a great question. And the answer is yes. The relative proportion of intracerebral hemorrhage to ischemic stroke is actually much higher in Asian populations. like our split in the West is like 80-20 ischemic stroke, intracerebral hemorrhage, and in Asian populations, in some places it approaches 50-50. Nobody really knows why. It's one of those things, everybody knows the answer. The problem is that everybody's answer is different. So we don't really understand that. So there undoubtedly are genetic factors and other environmental factors that contribute to this.
Great. Appreciate that. No, that's why we have the lipid panel. The lipid panel's here, to make all of us aware of unique presentations or unique cases, or as I said before, if you don't consider it, you'll never, think about it. So, I think the take-home message is that this is a unique presentation and a rare event. I think statins, as Nick highlighted, are the foundation for what we do, but I also think that having very low LDL cholesterol via the PCSK9 studies is not an added risk for clinical events. So I think that's comforting to us. As today I saw 2 of my patients with LDLs of 12 and 15. So I feel better about it having heard from Nick tonight, and better about it from hearing from you tonight, Brett. But I think it's great. And I think the Statin trial will give us some light on this unique presentation. When are they completing the trial, Brett?
It's got a ways to go. It's going to be at least a few years. Enrollment is slower than expected, which is always the case with stroke trials.
Right. Okay. Nick, do you have anything else you want to add from the very low LDL trials for us?
I think we hit a lot of the key points I want to make. Maybe I'll just add one point about the elderly, because while it didn't come up here, although I think, was she 76? It's a question that comes up. I know, for example, in our PCSK9 trials, I have had even cardiologists concerned about enrolling older patients for reasons like this. And so I feel like I'm saying meta-analysis a lot, but it really is the best available evidence we have when we have a lot of trials. So we had done a meta-analysis of all the lipid-lowering trials and focused on the elderly patients over 75 years of age or older, and looked both at efficacy and safety. And so I guess for the purposes of this talk, I'll just focus on the safety, but that included looking at hemorrhagic stroke, and we didn't see a significant signal there. And it of course was efficacious. So I think, the idea of holding back on lipid-lowering therapy for the elderly is not something I'd recommend based on the clinical trial results, both efficacy and safety. They do have benefit, significant benefit, just as much, if not a little more, because they have higher absolute risk than kind of middle-aged adults. And we did not see any safety concerns there either.
Great. I think that's a great point. And again, this particular patient, when she was unmasked off statin therapy, had a lipid profile suggestive of heterozygous FH. So she would have had a lifetime risk of exposure, high cholesterol translating to increased risk for early cardiovascular and cerebral vascular events. So, with that, we have over 40 people in attendance that were excited to hear about this. And I'd open up to the audience now. If anyone has any questions and they want to put it in the chat for whether what they should be doing, or, hear from, Brett or Nick or Deepak about anything else, now's the time. Other than that, I thought it was, very interesting. And I'll get back to the other question, so when you have someone, Nick, if her LDL was 77 and she was primary prevention and lacking an event, but secondary prevention and coronary disease, are you going to add anything to her rosuvastatin 40 at that point, or you're happy at 77, or you're happy at 80?
Well, I would push it down, and I've certainly have done that. It's always a discussion, of course, but I always try to push and add ezetimibe, and try to get it more kind of in the 50-50 or 50, somewhere around there.
Right.
Because again, I think it's you just get continued benefit. The lower the better. The longer you're lower, the better. And these drugs are well tolerated, and statin and ezetimibe are very accessible.
Right. So you would go statin ezetimibe with the option of PCSK9.
Yeah.
And then Brett, for your patients that present with ischemic stroke, are you adding secondary non-statin therapy onto your statins, or you're leaving it up to the cardiologist, the lipidologist?
Yeah, it's a great question. I think vascular neurology is a little slow to absorb the data for lower is better in terms of adding additional agents. I mean, I think we're all pretty much on board with, we just start at high dose statin therapy out of the gates. We're not like titrating or anything, but adding second agents is not really that widely done, even though it probably should be. So there's a lot of room, I think, for improvement in vascular neurology in that respect. And I think this is where the collaboration between, lipid folks and vascular neurologists is really valuable. The PCSK9 inhibitors are difficult for a lot of neurologists because we don't, have a big practice. We don't have anybody to teach them how to give them. We don't want to deal with insurance, right? And so there's a lot of kind of structural barriers to even sort of thinking about that.
Yeah, well, I think that's a good point, and we're challenged with that as well, even that we have all the tools. But let me ask you even another question: how often or when do you order an LPA on your patients that come in with stroke?
It's funny that you say that. The fellow I was seeing a patient with today in clinic wanted to order LP little a in our last patient. And I said, I don't think we should do that.
Okay.
It's really tough because we really just don't know what to do with it in stroke, right? I mean, I'm not sure you guys know what to do with it in general either. Obviously, it's associated with increased risk. I think that's pretty clear. If you've got somebody who's 75 and has a stroke with intracranial atherosclerotic disease, they've got athero. You're going to put them on a statin either way. What's the, added benefit to switching them to PCSK9 inhibitor? Does that change their event rate? I think we don't really know. And since we don't really know, I don't really like to order it because it hurts my brain to think about it. But we do order it more in younger people. If we have younger people with normal routine lipid panels who have clear atherosclerotic disease in their blood vessels that we feel is unexplained, and that's a scenario when we are often ordering it just so we have some idea as to what's going on. And then we send it to Dan to figure out what to do with it.
Oh, Dan, but we have Dan is watching over us. But Nick, so what do you think about that? Now we potentially have an elevated LPA. Are we looking to switch these people to PCSK9 for potential benefit and LPA reduction?
Yeah, it's a good question. I mean, first I'll just say, the data for LPA and its association with ischemic stroke hasn't been too strong or too good to the point where, in these LPA trials, outcomes trials, we're not even using ischemic stroke as one of the endpoints because we're not necessarily convinced it will lower that endpoint. But of course, I'm mostly seeing patients with coronary disease or dyslipidemias or risk for heart disease, and so I'm checking it on pretty much everyone, kind of the one time in adulthood to see if it's high. And I think it's helpful. It's helpful to kind of guide discussion in many ways. For one, if patients have had early disease or plaque and they learn their LPA is high, they understand why. It's nothing they did or didn't do. It's genetically mediated. They can also have family members screen, which I think is useful. So even before you get to how you treat them with therapy, there are some things that impact care. But then it helps me be more aggressive about therapy, as you said. So we're kind of debating, are you okay with 70? Do you want to go down lower to 50? The LPA kind of makes you be more aggressive. And of course, PCSK9 inhibitors is one of those ways to be more aggressive. And it's nice because it lowers Lp(a) by 25 to 30%. I mean, as Brett said, we don't really know if lowering LPA to that modest degree actually is going to translate to clinical benefit. But, we're always trying to do what we can for the patient, and we know the LDL lowering will have benefit. So I try to maximize LDL lowering to offset the elevated LPA when it's there.
Okay, so another question. Do you think switching to like Zetia, which has a different mechanism, ezetimibe, would be a good approach, Brett, in terms of avoiding statins? LDL reduction.
I think that's kind of a reasonable approach if you have somebody who has a lobar hemorrhage who you really think needs cholesterol lowering, is to choose an alternative agent like Zetia or PCSK9 inhibitor. you know, granted that we're not exactly sure what the risk benefit ratio is there, but it seems like there's less of a concern probably.
Okay, great. Now just a bunch of potpourri questions, some from the audience. Deepak, just quickly, what did the patient wind up on for lipid lowering therapy when you guys saw him in the clinic?
Yeah, PCSK9.
So they went to PCSK9. Okay. And then again, we'll answer these quickly because we're running against the clock. Should we start considering doing calcium scores in our secondary prevention population? Since coronary calcification could mean vascular inflammatory disease elsewhere.
Well, in the secondary
I guess
prevention population,
Yeah.
I guess the secondary prevention already has established disease, and so don't need, CACs in those patients. CACs more for the primary prevention, and I think it's helpful for risk stratification. Again, we've mentioned some other things that are helpful for kind of deciding how aggressive to be or whether or not to start a statin. And I think CAC, LPA, HSCRP, these are helpful risk enhancers that can help you kind of put everything together for an individual patient.
Okay, good. Brett, is there any information on blood pressure control in these patients with recurrent ICH in addition to statin and LDL reduction?
Yeah, I mean, definitely blood pressure control is a very powerful reducer of recurrent events. Absolutely. So all patients with lobar or deep hemorrhage need their blood pressure less than 130/80.
Great. All right. So I think, we've answered a bunch of questions. And again, I think it's important for us to understand that this is a unique clinical presentation and it's something that we need to consider. So now we're aware of it. And certainly some of the things that Brett pointed out to us are important for us and clinically when we see these patients. And I think Nick reassured us from the data we have from Fourier that LDL low or low LDL does not necessarily cause an increase in untoward events. So with that, we don't know the exact answer in terms of statins' direct effect on causing intracerebral hemorrhage. So we'll have to reconvene the lipid clinic or lipid panel, I guess in a few years, according to Brett. I think it's appropriate that if a patient is on statin therapy and has a unique presentation of intracerebral hemorrhage, if we hold the statin, PCSK9 therapy, and our other non-statin therapies are totally appropriate and indicated to get these patients to our LDL target. So it's great that we have the means to accomplish the mission. And, with that, I want to thank, Deepak for a great case presentation and enlightening us this evening. And, Nick and Brett for enlightening me as well as the rest of the lipid panel for, what we have to consider when we see these type of patients. So moving forward, appreciate your input tonight, and I appreciate everybody joining us from the audience in tonight's lipid panel. And I look forward to everyone joining us in the last Tuesday every month for more lipid enlightenment. So thank you again. Are we
Thanks,
off the live
everybody.
feed? No, there's Dan.
Not until all the participants have left. So we are still live, but that was great.
Yeah, that was
Great
fantastic.
conversation.
It's great. I would take